I think this.
Yeah.
We are live.
Yeah. So
Very good evening to everyone. And today we have once again come together for the iFocus online session, and we are currently running the Cataract module. Today we have the esteemed speaker, Dr. Chitra Ramamurthy, ma'am. She will be taking us through the techniques and principles of surgical management for subluxated and dislocated lenses. We welcome you, ma'am.
hello. I truly consider it as a huge uh, prestige to be talking in this online program. So, do I get started?
Just give me a minute, ma'am. I would also like to welcome the moderator for today's session, Dr. Piyush Bajaj, sir. Sir has done his MBBS from Manipal College and DOMS from Rajiv Gandhi University, Bangalore, and fellowship in oculoplasty and cataract. He's currently associate consultant at Center for Sight, New Delhi. Welcome, sir. I would also like to invite and welcome our chairperson for the day, Dr. Avnindra Gupta. He has done his MBBS and MS from BHU and fellowship in retina from Aravind Madurai. He's a consultant in vitreoretinal services. He has been a consultant in Aravind Madurai and has in charge of the Department of Retina at Vitreous at the Aravind Tirunelveli station. Sir is a very senior vitreoretinal surgeon at Center for Sight, Safdarjung Enclave. He's also a director of Nayan Jyoti Eye and Laser Center. Sir has more than 52 research papers in his name. He has run various instruction courses in AIOS, APAO, VRSIS chief instructor, and he's the part of number of instruction courses as co-instructors in American Academy, ESCRS, APVRSI, APAO. He has presented very difficult cases at various forums, and his classes are one to be sought after. Let me tell you that. So has also been awarded many best video awards. He has been to U Retina, and his video title Mystery Unfolds also was awarded best video. It is a great honor, and sir has with his esteemed presence, he's blessed us today. And moving on to our speaker of the day, Dr. Chitra Ramamurthy, ma'am. Ma'am, I welcome you again. Ma'am is the medical director of the Eye Foundation. It is a chain of more than 20 eye hospitals in South India. Of course, that name is known to everyone. Ma'am is also the president of Coimbatore Society of Ophthalmic Surgeons. She is highly proficient in cataract, refractive, glaucoma, you name it. Ma'am does it all and teaches us all. She has had the special distinction of conducting innumerable instruction courses in both India and abroad in ASCRS, APO, APACRS, and ESCRS on a very regular basis. Ma'am has innumerable papers to her credit, both nationally and internationally, and she's contributed to multiple chapters in various textbooks also in refractive surgeries. Ma'am has held, I think, the most number of positions a person can hold and managing everything, juggling together very beautifully. Ma'am has been the chairperson of Academic Research Committee ARC AIOS from 2020 to 23. She's been the member of Scientific Committee from 2017 to 20, and she's also been the chairperson in Scientific Committee of Tamil Nadu Ophthalmic Association from 2002 to 2015. Ma'am has been the past management committee member of the TNOA, and she's received best paper awards in the state and national levels. And you can see there's a big paragraph where ma'am has won so many awards, and I'm sure there must be more which could not even fit this slide. Ma'am, it is an honor to have you here. And now I would stop sharing my screen. Ma'am, please go ahead. We are eager to listen to your talk today.
I'll share my screen. Is my screen visible?
Yeah, it's visible, and you are
Yes.
audible too.
Yeah, and first and foremost, I did get an opportunity to talk earlier in your iFocus online programs, and I truly believe it's an ultimate honor to be back here. And I do hope the next 45 minutes to an hour is of some value addition to your very terrific series of programs which you are been conducting all along. Thanks for that very nice intro. I was touched to the core. So let's get on. My due in the next few minutes is about managing subluxations. Now, let's get to know a bit of the basics. Like we all know that the lens is suspended to the ciliary body uh, with the help of zonules. And these are anterior and posterior zonules. The anterior zonules and the posterior are attached to the lens substance. The anterior extends about 1.5 millimeters more anteriorly, and the posterior about 1 millimeters. Now, these fibers, which are very strong with age, they do tend to become more fragile and actually become fewer in numbers. And these zonules are rich in fibrillin, which in turn is rich in cystine, and it is also extensively disulfide bonded. Now, fibrillin, cystine, down any deficiency in these or any genetic difference can all cause these zonules to become weak in some of these syndromes. Now, when a lens is displaced from its normal position but remains in the pupillary area, it is called subluxated. And it's called a dislocated lens when the lens is completely moved out from its area, comes anterior into the anterior chamber, or gets posteriorly dislocated into the vitreous. Now, the broader classification could be like you differentiate it as the congenital causes or the acquired causes. But in the acquired causes, the most common reason for subluxations is a traumatic origin, followed by iatrogenic. But then there could be some primary ocular conditions which I would enumerate, which is associated with subluxations, some systemic conditions which are associated with ectopia lentis, and there is a hereditary ectopia lentis which presents itself without any systemic associations. Now, what is it specific to know about the traumatic subluxation is the good news is it is a non-progressive. Like at one point of time, there has been an injury to the zonule fibers and the damage remains to the extent of damage which has happened. And though, yes, we know it's a very common cause, but of course, it could be associated with other ocular injuries of pupillary sphincter tear. It could be an iridodialysis. There could be a cataract. There could even be a vitreous hemorrhage and a lot more. Iatrogenic is a situation which occurs during a cataract surgery where inadvertently you pull on the capsular fornices of the bag and the bag gets subluxed. And then the extent of damage or how are you going to treat it depends on the extent of zonular weakness. And if it's something very small, just inflating it with viscoelastic and going on to placing an intraocular lens with the haptic aligned along the area of dialysis may all that be enough, or you may need a CTR, or you may need more based on the extent of dialysis. There are certain primary ocular disorders, which are again a kind of a degenerative process, like in a pseudoexfoliation syndrome, or in a hypermature cataract, or hypomyopia, or in coloboma, or in RP, and many more of the things which I've enumerated, wherein zonular weakness could coexist with subluxations. Again, certain systemic conditions which need to be kept in mind, of which Marfan's is the most common, followed by homocystinuria, seen in fewer cases, and Weil-Marcesani syndrome, hyperglycemia, and all of these, which I'm not going to enumerate in line, but these are very important for the young postgraduates to know. Now, what is most important is that the Marfan syndrome is the most common form of heritable ectopia lentis. It is autosomal dominant. Now, there's a mutation in the fibrillin gene in this particular case, which is the causative factor of the less amount of fibrillin, which is a very important constituent of the zonular fibers. These are invariably bilateral, and the dislocation is superotemporal in majority of the cases, and which is a distinctive feature of Marfan syndrome. And it is associated with high myopia, flat cornea, scleral thinning, and even retinal detachment. The important systemic features, which is so characteristic of Marfan's, is a tall stature, a pectus excavatum, and a scoliosis. The other interesting thing is the joints are very hypermobile, as against another syndrome I would talk to you later, where there's more of a stiff joints. And they have long tapering fingers and toes, which is called arachnodactyly. There are certain cardiovascular associations which should keep us on watch, is the aortic dilatation, dissection, aneurysm, or a mitral valve prolapse. And these are factors which has to be kept in mind if it's a Marfan's and it needs to undergo a cataract surgery. The homocystinuria is a less frequent occurrence. It's autosomal resistant. And here, again, it's bilateral, but the dislocation is not superotemporal. It's inferior and nasal. And it could again be associated with high myopia as in Marfan's, and it could create a pupillary block glaucoma and or a retinal detachment too. Now, systemically, what is differentiating is although it has a Marfanoid habitus, there is an intellectual disability which is characteristic of homocystinuria. And of course, the chest deformities may be similar. The other very important thing is the anesthetic risk it poses because there's a cystathione beta synthetase enzyme which is deficient here. There's an increased level of homocysteine which affects the blood vessels and creates thrombotic episodes in these eyes. So that's a very major risk which has to be watched by the anesthetist when these eyes come up for surgery. The Weil-Marcesani syndrome, it could be a dominant or an autosomal recessive. Commonly, they have microspherosphakia as a representative of the lens configuration. They could be myopia, but normally myopes come with a deep AC. Here it's a shallow anterior chamber. There could be subluxation, there could be dislocations into anterior chamber, and they could be associated with a secondary glaucoma. Systemically, against the Marfanoid habitat, here it's a short stature, short fingers or toes, and progressive joint stiffness as against the hypermobile joints in Marfan's, and of course, thickened skin. And another thing which it shares with the homocystinuria is a mild intellectual disability. Of course, there are certain cardiovascular associations like patent ductus arteriosus, pulmonary stenosis, and many more. The other kind of hereditary anomaly is where there is no systemic association, which is ectopia lentis et pupillae, which is an autosomal recessive, where the lens and the pupil are dislocated in opposite direction. It could present with a persistent pupillary membrane, a microspherophakia, a large corneal diameter, increased corneal thickness, and other like coloboma and even a high retinal detachment and some iridohyalite adhesions. Now let's get to the most important part, the clinical presentation. Now these patients would present with decreased vision because of the progressive subluxation. So there's going to be frequent refractive changes and a highly irregular astigmatism. That's an important factor to note. And because of the highly irregular astigmatism, there's an associated amblyopia. And there could also be a monoocular diplopia if it bisects the pupillary margin, if the dislocation is such. If it gets displaced into the anterior chamber, you could have an acute angular closure glaucoma. If it gets displaced into the vitreous, there could be lens protein-induced uveitis, a vitreotraction, or an RD. And there could be associated signs of trauma, which has to be looked for if the etiology is trauma. Now, what do you need to do? You need to do a thorough ophthalmic evaluation, and especially in the congenital cases, you need to refer it to a physician who has to do a thorough systemic evaluation, do a metabolic screening, do an echocardiography, needs to evaluate other family members, and mandate an annual ophthalmic examination. Now, when you do refraction, invariably, these are high myopes. There is astigmatism. But what you need to do is, you need to do refraction in the phakic and the aphakic portion. And whichever gives the best possible vision, we would use that correction for the particular patient. Slit lamp evaluation is the next thing after clinical evaluation and refraction. The AC depth is going to be irregular. Naturally, there's subluxation. The AC is going to be unnaturally deep in one area, shallow in the other. And along with subluxation, there could be vitreous disturbance. So let's think logically, step by step. And then when you look at the lens, there's phacodonosis. Now, if you want to actually identify phacodonosis, is best appreciated in a undilated pupil, because in a dilated pupil, the lens gets better supported by the ciliary body. So that's another important point to note. And they could, lens configuration could be spherosphakia, microspherophakia when you have to do an EAC-PI. And you need to look at the amount of subluxation, which has tell you how to treat, and also the direction of subluxation, which will aid you in the diagnosis. You need to look at the grade of cataract, because that would tell you whether you're going to do a surgery now. And you need to assess all of these patients in a supine position, because if the lens sinks a little more into the vitreous, then you have to manage it by the pars plana route. Slit lamp evaluation, you need to look a lot more. You need to look at the appearance of the zonules. If it's nearly absent, it's homocystinuria. If it's elongated, it's Marfan's. And if the lens equator, which is going to be visible, looks rounded, you know that extent there is zonular weakness. If there is associated injury, like you can see a pupillary tear, sphincter tear, and iridodialysis, a cataract, and other things. It could also be secondary to ocular comorbidities, which I alluded to earlier. So you might have to look for pseudo-exfoliation, or is it a hypermature cataract? Is there RP if you do a fundus evaluation, or is there a coexistent coloboma? You have to look at the angle because there could be an angle recession if it's trauma. The angles could be closed in some form of a subluxation. They would need to do a fundus evaluation to prognosticate the visual prognosis of these eyes. And if the cataract is dense, you need to do a B scan. You also need to know the status of retina because retinal detachment could coexist in some of the syndromes. You need to do an OCT macula, which often tells you more than a fundus evaluation. You need to do a specular microscopy because you need to know the endothelial status before you plan surgery. And because of the extremes of axial length in these eyes, it makes sense to use the latest generation formula and UBM wherever indicated. Now, when it comes to the management, if you can get away with an optical correction and a clear lens, that's all that's needed. But again, there could be a secondary glaucoma, so you need to look at the IOP, which needs to be treated. Is there damage to the iris? Is there a traumatic origin, which has to be handled at the same time? And when would you operate? Now, indications for surgery, yes, of course, if it's defective vision and cataract, that comes to be the primary cause. But in a child with a subluxated clear lens, also you might consider if the vision is not getting adequately corrected by spectacles, like if the lens equator bisects the visual axis. So it's going to cause diplopia. It could also cause aberrations or amblyopia. And when is surgery urgent? If it is subluxated in the anterior chamber or it's tilted posteriorly into the vitreous cavity. Next comes some consideration. What is the degree of zonulopathy we need to know? We need to know the pathophysiology. Is it a static one, like in trauma, or is it progressive in nature? We have to keep in mind the experience of the surgeon, whether there are ocular comorbidities, there are systemic comorbidities, whether you are going to decide whether you're going to do the surgery under local or general anesthesia. But what is the final goal? The goal is that we need to extract the lens safely. We need to minimize vitreous loss, and we need a stable IOL fixation at the end of it. Now, supposing you decide that you're going to manage the whole scenario with phacoemulsification, there are certain annuals of support you need. You need to keep in mind that you may need a CTR or iris or a capsule retractor, a modified CTR or a CTS. If you're going to do lensectomy, you would have to take a call whether you're going to do the limbal route or the pars plana route. Then are you going to put an ACIOL, an iris clip, iris suture IOL, or an SF IOL are the things which come to mind. Now, when you see zonular weakness, what you see on the slit lamp, yes, would be able to stratify whether it's a mild, moderate, severe, or very advanced subluxation. But what you see on the slit lamp is actually may not be what you're going to see under the operating microscope. And believe me, you should be prepared for a greater damage than what you saw on the slit lamp. So let me reel off some pearls. Like anesthesia, yes, if it's pediatric, you may need general anesthesia. Definitely, cardiac evaluation is a must. If it's an adult, you don't know how long the surgery is going to take and what are the challenges which are going to waylay you. So you would use a regional block. You would use an IV mannitol when indicated because you want to decompress the vitreous. You want a softer eyeball to operate on because there could be anything which can crop up, a malignant glaucoma, suprachoroidal hemorrhage, anything can come up. When it comes to creating a CCI, you start from the center and go towards the region of the attached zonules. You should check for vitreous. You can use the tricot stain and understand whether you're going to do the vitrectomy from the limbal route or the pars plana route. Now, another important thing, you need to remember that if you straight away go and stain the anterior lens capsule, the trypan blue will go through the area of zonular weakness and behind the vitreous, and you will lose your red glow, and that's going to be a huge challenge in your phacoemulsification. So it makes sense to go ahead and inject OVD over the anterior lens capsule, and then over it you can stain, use trypan blue stain. The advantage of trypan blue stain, yes, the stain may not take up so well, but then it definitely is going to reduce the capsular elasticity because one, the capsule is elastic in these young guys, and there's a pseudo-elasticity which is imposed by the zonule weakness and the subluxation. So then the most important thing to do a good phacoemulsification is to get a complete rhexis, capsulorhexis, because there's a huge area of loss of zonular countertraction. And as I said earlier, it has an elastic lens capsule. So what do? You're going to inject a highly retentive viscoelastic to flatten the dome of the anterior capsule. You're going to initiate the rhexis from the area of intact zonules with a sharp needle going in through the side port. I would not want to do any of my approaches from the main port for doing the rhexis because I do not want the viscoelastic to egress from the main port. I don't want shallowing of the anterior chamber. One, the rhexis will run away, and shallowing of the anterior chamber could also increase the area of zonular weakness. And once I've made the neck, I would propagate with a microforceps. As I start my rhexis, beyond a point, I could use capsule retractors 2 to 3 clock hour away from the leading edge to hold or give that counter traction to the rhexis margin as I initiate my rhexis. I would want my rhexis to be centered to the capsular bag, which is important to note, not centered to the lens surface. And I would like to have the rhexis margin, at least 2 mm margin all around to support the CTR. And this is what is going to be shown here. Now, if I were to do on a laser cataract platform, there's one advantage. It doesn't matter. I'm going to get a rhexis even if there is no counter resistance provided because of the lack of zonular support. And I would get a circular capsulotomy. I could decenter it if I want. But then I wouldn't definitely not do it in a very grossly subluxated lens or a poorly dilating pupil. Now comes the next pearl, the stabilization of the anti-capsular bag. Now, again here, it depends on the etiology of zonular weakness. It is non-progressive or progressive. If it is non-progressive, maybe a CTR would suffice if the area of zonular weakness is not very extensive. And because the remaining zonules will take on the work of that absent area. But if it is progressive, like in pseudo-exfoliation or Marfan's, you need to fixate the bag to the scleral wall. Now, there are other anvils of support like iris hooks and capsule retractors, which you are going to need, and also the CTS, which you're going to need if you're going to fixate the bag to the scleral wall. Now, what are CTRs? These are open compressible PMMA rings, which have a rounded eyelet at the end. And what it does, it actually, if you're inserted into the capsular bag, it expands the capsule equator. It actually buttresses those areas of weak zonules, and it redistributes the tension from the existing zonules to the weak areas. It also tightens the posterior capsule and sort of stretches it and enhances the safety of the cataract surgery. And it sort of recenters that mild subluxation of the capsular bag, and hence the IUL also gets centered and gets stable. And it also, because it stretches the capsular bag, it prevents the capsular shriveling and also getting tamponaded into the phaco probe. And most importantly, by the stretch and preventing the capsular shriveling, it also decreases the occurrence of PC. Now, the diameter of the CTR should be slightly larger than that of the bag. Now, if you look, and also it relates to the axial length. As you can see in this table, the axial length is less than 24 millimeters. The compressed CTR is 10 millimeters, the expanded is 12.3. If the axial length is 24 to 28, the compressed CTR dimension is 11 millimeters. If it is more than 28, it's 12 millimeters. And remember, the ends of the CTR have to overlap to provide a full circumferential support. Now, the indications. The CTR will suffice if it's a mild to moderate segmental zonular weakness or if it is a non-progressive zonular weakness. But when would you not place a CTR? If there's an anterior capsular tear, if there's a posterior capsular rent, if there is an incomplete rhexis, or if it is severely subluxed capsular bag. Now, there is this saying which goes like, you place the CTR as late as you can, but as soon as you must. Now, when would I like to place it early? When the bag is weak, and I know that it's not going to withstand the stress of phacoemulsification, then I would place the CTR early. What is against that placing it early? Supposing it's a dense nucleus, and I'm not able to clearly visualize the CTR, and I'm pushing my CTR in, I might induce a larger dialysis. And then I also know it's going to be difficult to strip the cortex and get my nuclear fragments around the place unless I do a good dissection. Now, when would I use it late? Now, the advantage of late is so much more. One is the capsule bag is empty. I can easily insert it. I can see it going round, and I can see the overlap of the end to end of the CTR, and the cortex is not getting trapped here. But then Now, imagine if I have a weak capsular bag and I plan to do a phacoemulsification and I'm not place a CTR, then the least I could do is use capsular hooks or iris hooks to support the bag if I'm going to delay placement of CTR. Now, why would I use an iris hook or a capsular hook? There are huge advantages. Once you initiate the rhexis, the capsular hook and or the iris hook, less commonly, would give the counter traction so that I can complete my rhexis. It also will keep the bag stretched so that I can place my CTR. And it also prevents the lens from becoming wobbly, gives better centration. And by stretching the capsular bag, it prevents the chances of vitreous prolapse, which could occur if that area of zonules where dialysis was exposed. Capsule hooks are of nylon material, whereas the iris hooks are of polypropylene material. The iris hook has less of a role because it only supports at the rhexis rim, whereas the capsular hooks, the way they are configured, it supports right up to the equator. So it prevents any fluid going back and causing a fluid misdirection, which could become a huge challenge during a cataract surgery. Now, for example, here, the CTS is placed, and before you are going to go on to do the raid rolling and suturing the CTS to the sclera, placing a iris hook, look how it keeps the CTS in place at the primary stem. When it comes to phacoemulsification, yes, you have to do a good hydro, gentle hydro, not to over-distend the bag, so that there's free rotation of the nucleus. And then you need to do a slow motion phaco. If it's a soft cataract, you're just going to aspirate it. If it's a hard cataract, keep the phaco probe in the center, do gentle phaco chops, and keep the nuclear fragments confined to the safe visible area. And at all times, maintain the anterior chamber. Now, cortex aspiration. Now, there is always a tendency that in this, if the anterior capsule and the posterior capsule is lax, you might actually pull on it because of the zonular tension being absent. And also the CTR is going to trap the cortex. So you should actually do a good hydro before you go on to that first step of CTR insertion. And it's better to do a circumferential stripping of the CTR. And the Henderson CTR is one way wherein you are able to go into deeper into the capsular fornices to remove it. IUL implantation, you need a right size rhexis, it's centered capsular bag. You could use a single piece foldable if it is, because one, it's so easy to implant and gentle unfolding. And if it is a smaller amount of dialysis, a single piece IUL is fine with a CTR. But there's an advantage of a multi-piece IOL because the rigid haptics itself is going to support the zonule in that particular area of weakness. And supposing it's later a pseudo-exfoliation is there, this multi-piece itself could be used for glued IOL fixation. You could also place a multi-piece IOL in the sulcus and do an optic capture because that itself is going to decrease the pseudophacodonosis. And that's one other way of getting your IOL centered in the capsular bag. And what would be the IOL type? Invariably, it's going to be a monofocal, but in a non-progressive zonular dialysis, even a toric IOL can be planned with a CTRs, like in a case of a trauma, because it's not a progressive zonular weakness, but at all costs, I would avoid a multifocal. And if it is a large zonular weakness, I would have to fixate the bag to the sclera. So then I would use a CTR and CTS or one CTS or two CTS, a CONE CTR. And the suture material, which is now popularly used, is a 90 polypropylene, which has a better biodegradability and or a Gore-Tex suture. Now, the CONE CTR can come with one eyelet or two eyelets. And what happens is this short loop it comes perpendicular to the CTR plane, that is anterior to the capsulorhexis, and the sutures are passed through these eyelets into the ciliary sulcus for scleral fixation to stabilize the bag and center it. Now, these Ahmed segments are used for 4 to 8 clock hours of zonular dialysis, and CTR is implanted in the bag with the eyelet again anterior to the anterior capsule, and then sutured to the sclera. There are other things like the ASI anchor, the glued capsular hook, or the paper clip, or if there is a trauma and there's associated iris defect, whether congenital or traumatic, there are these mortuaring segments which could also be used along with the CTR. Now, I'm going to show you just 3-4 surgical videos. Now, here you can see, now this was the surgery nearly completed, and now it was just about removing the cortex and look, I have a dialysis, iatrogenic dialysis. So I just let go and then inflate the capsular bag with viscoelastic. I could have placed a CTR now, but I'm keeping a watch in that area of dialysis. It's not extending. And very gently, I do a circumferential stripping. Then having removed the cortex, inject viscoelastic and inflate the bag, and then place my CTR and position it such that the full length of the CTR comes to overlie the area of zonular weakness and the eyelets overlap. And then I would place my intraocular lens and ensure that the haptics are also oriented in the area of dialysis and the surgery is well managed. Now, this is the case wherein I'm not very clear. I feel there's phacodonosis. I stay in the capsular bag, but it isn't exactly wobbly. I start off with a small rexus because it's always makes sense when you're unsure, make your rexus small. I'm actually able to complete the rexus, and I wonder whether I had actually had a zonular weakness. But then, however, I decided I'm going to place capsular hook. It's a fairly dense cataract and not a too well-dilated pupil. And this capsular hook is going to buttress right up to the equator. The nucleus has to rotate well. And then I start my job. Things appear fine. There's nucleus rotation, so there's no vitreous for sure. But then that area, see, superiorly, I see that area of zonular dialysis. I go and place one more hook because I don't want the vitreous to come forward. And then, what's happening? Sorry. Then here, what I see is, I decided that I'm going to place a CTR now. At one point, I feel the capsular hooks alone is wrong to suffice. Keep my phaco probe in the center. I have already chopped the nucleus, so I start removing it. But I'm somehow not feeling very comfortable about the capsular bag. It feels very lax. I'm not clear how much you're able to see. I bring down my phaco parameters all through the surgery. But the cortex is yet to be removed, but I place my intraocular lens at this point itself, like let it work like an IOL scaffold and push back the posterior capsule. And there is some small tiny fragment and epinucleus, and then I strip the cortex, and then I loosen my capsular hook, and then complete my cortex removal, and the surgery gets completed and eventually. Now, this is a case of a traumatic subluxation, fairly large area, just held with zonular fibers here and there, but it was on a femtocataract platform, and I've aspirated it and I stripped the cortex. And the last area is the area of that large area of weakness, which is being stripped. And then I place my CTR. Actually, in hindsight, I should have placed the CTS2. But at that time, so many years back, I had done this. And that CTR is well protecting that area of zonular weakness. I placed my intraocular lens. I imagined a small amount of vitreous there and I cut the vitreous. And this patient has been coming ever since and is absolutely stable. Now, this is a fairly simple situation where from the beginning, the capsular bag looks very weak. But I don't perceive any zonular dialysis, but I decide that I'm not going to do any phacoemulsification in the capsular bag. Then I bring the nuclear fragments forward and keep it in the pupillar area, enough viscoelastic, not to overdistend the capsular bag, but yes, enough viscoelastic to coat the endothelium because it's literally anterior chamber phacoemulsification. I keep my parameters low. The IUP is at 40. And then I bring those pieces towards a 6 o'clock position. And it's a very gentle, slow motion phacoemulsification. But everything looks all right. I know the fact that there's a followability of the nuclear fragment. There's definitely no vitreous there. And apparently there is no dialysis either. So do I place a CTR? I can see how the capsule is thrown into folds. So I inject viscoelastics, stretch the capsular bag. The CTR can be a nuisance when it comes to removing the cortex. And as there was no evident zonular dialysis, which could extend and totally change my surgical course. So I keep inflating the capsular bag, keep stretching it, and very gently keep getting to remove the cortex. I'm able to strip the cortex far more easily than had I placed the CTR and unless I'd done a real good hydrodissection. But there is still, the thought keeps coming into my mind that it's not such a big bugbear that I couldn't have placed a CTR. But then I keep going on. It's just one of those days when your mind forces you to do certain things, thinking that is the best way to handle that precise moment. And I somehow managed to strip the entire cortex and even those small, tiny tags, everything I remove. And it is now, after I've removed the entire cortex, I see the fact that the rexus looks centered at all times is another indicator that there is no zonular dialysis as yet. Because if there is a zonular dialysis, the bag itself would look decentered. So in a very slow, gentle circumferential stripping, I strip out our entire cortex, and then I actually place my CTR and finally complete my case. Now, this is a case where there is a coloboma of the iris and the lens. So here I create a Hoffman's pocket. Now, after creating the Hoffman's pocket, what I do is I inject viscoelastic in that area of zonular weakness because I'm going to tamponade the vitreous there. I don't want fluid misdirection. I create my rhexis well away from the area of the coloboma. Gentle hydro. I don't want fluid to go behind. Very gentle hydro. It's a very soft cataract, so I aspirate it. And now I'm going to place my CTR into the capsular bag and follow all the dictums. The arm of the CTR in the area of the zonular weakness, the eyelids away from that area. And once I positioned it, actually, this is a case, this is a stationary zonular weakness. There is actually no need to have placed a CTS. The logic here was there could be an asymmetric back contracture in the postoperative period, which may not be, could be avoided if I place a CTS and then attach it to the sclera in the Hoffman's pocket. And that's how it was done. This is a case of a very extensive zonular weakness. So again, a corneoscleral pocket is created where I'm going to fixate the CTS. And first step, as I said, I'm going to inject enough viscoelastic at the site so that I prevent fluid misdirection. Now, getting to do a rhexis in these eyes is actually a huge challenge. And you sometimes you could start off the rhexis and place your capsular hook to give it some amount of counter traction to complete it. But this was a small rhexis and it was a very soft cataract. And with the IA itself, you're able to aspirate all the entire content of the soft nucleus. And then at this point of time, I would inflate the bag with viscoelastic. And after doing that, I would loosen my capsule hooks at this point of time. And then I would place my CTR. Now it goes without saying it's a grossly subluxated capsular bag, and a CTR is just going to open up the capsular bag, but you need to place a CTS. Based on the extent of dialysis, you will decide whether you're going to place one CTS or two CTS, and then you're going to railroad it and suture the CTS to the scleral wall, and then and tighten the suture based on how much the IOL needs to be look centered, and then you would bury the knots in the Hoffman's pocket. Then, of course, this is again another case of a lens coloboma, which I'm showing you. Now, it's a fairly soft cataract. So I make my incision and then again, I go and inject viscoelastic to, again, in that area of dialysis to push the vitreous back. And then you can see that I will not over-distend by inject too much viscoelastic in this case. And I would do a hydro, but I would not do too extensive hydro dissection. I just want the nucleus to be mobile. I don't know whether it's moving. And then I will go in with a micro forceps. I don't want my anterior chamber to shallow at any point of time. And as you can see that I'm doing just a simple stop and chop, and I'm able to aspirate the nucleus. So this far, I have not used my CTR at any point. And I continue to do my phacoemulsification. And now I even going to start stripping the cortex. Because, if you're going to feel any kind of a traction there, that means I have to stop in case there is some vitreous there. So I do get a doubt, then I place my CTR. So it is as early as you can, as late as you want. This is how you would deal it. Now, this is a case of a severe subluxation, a severe pseudo-exfoliation. So from the word go, I know it's very severe. Either I go into all the ways of anchoring the capsular bag, or why not I do just an SICS or complete it with the iris clip lens. And that's why I make my two side ports at 3 o'clock and 9 o'clock position. And it's a small pupil here. So I go in to just check that, make sure, yes, there is significant subluxation and it is quite visible. And I just go in with a scoop and I remove the entire nucleus out. Normally, at this point of time, I would do an anterior vitrectomy and then I would inject pilocarpine because I want significant iris all around to be where I could clip in my iris clip lens. But in this case, the pupil was quite small. So I take my iris clip lens, which has a 5 mm optic, and then I position it at 3 o'clock, 9 o'clock position and stabilize it with IOL stabilizing forceps, and then push a little bit of iris into that pincer-like haptics on either side. And then I would do a PI. And in this particular case, I haven't done a PI. But if I do have done a complete vitrectomy, I used to think that I wouldn't do a PI, but of late, I do a PI in all of these patients. This is a case wherein the patient came to me saying that the initial doctor had said that the bag was weak and a CTR was placed, but he was having diplopia. So I did explain to him that I would have to remove the bag, IOL, and the CTR either to the anterior root or posteriorly if I'm not able to access the CTR on the anterior root. But as I remove the IOL, I do see the capsular remnant there. So I just wish and hope that the CTR is entangled there. So I go in with my persons and I pull it out, and thankfully the entire CTR comes. In some situation where you're not able to get your CTR, it might be dangling in the vitreous, and it's important that you remove the CTR with the help of your vitreoretina surgeon. And this is an iris clip lens which is being placed in the sky. This is a case of a late capsular bag dislocation. The patient had a primary surgery 15 years back. And in this particular situation, you need to do a complete vitrectomy and get the IOL into the uh, front and remove it from the anterior root, and then an SFIOL was done in this particular case. There are certain postoperative issues which you need to keep in mind: uveitis, glaucoma, corneal edema, a capsule phimosis, a PCO, or an IOL bag decentration, late decentration, and dislocating into vitreous. The important thing is you should get an adequate size rhexis and not leave it as a small rhexis, because these eyes, because of the bag, capsular bag weakness, there could be a lack of traction on those some parts, and you could get a capsular phimosis. So one is you need to polish the anterior capsular rim in these eyes, never create a small rhexis, and if it is small, ensure that you make some relaxing capsulotomies in the primary surgery itself as a preventive measure. So I would like to conclude stating that I have taken you through a trail of subluxation and some pearls and some tips and tricks. And what comes across most significantly is that subluxated lenses actually need a very systematic preoperative evaluation. You need to have a surgical plan. You know your surgical plan might become different during the course of the surgery, but you need to have it all to get good outcomes. And a long-term follow-up is mandatory because we do anticipate problems in these progressive zonular weakness, and there could be a challenge of the IOL not being centered or later dislocating. And these are high myopes, and their retinas need to be evaluated at all times. So with this note, I would like to conclude my talk. Thank you very much. And thanks a lot, iFocus, Dr. Santosh, and the entire CFS for giving me this wonderful opportunity to.
Thank you, ma'am.
Thank
It was a wonderful presentation. You almost covered each aspects of subluxation. Uh, one thing, one thing I'd like to comment that you need to uh, check. There are certain situations where you should have a retina backup many a times. If you don't have a retina backup, you can get a dislocation of the lens into the vitreous cavity. And always three-piece lens should be ready in these kind of cases. One technique what we have described in JCRS also, that if you have in cases of traumatic subluxation, if you see vitreous popping out from the subluxation, what we do, we put an cannula in the area of subluxation and do a vitrectomy from behind. So by doing this procedure, what happens that you pull the vitreous behind. Don't do vitrectomy from anterior segment. Once you do vitrectomy from behind, the vitreous goes back. And many a times, one thing what you were telling, ki prevent hydration of the vitreous. So if hydration of the vitreous occurs, then the capsule tends to pop up.
Yeah.
So this cannula also prevents hydration of the vitreous, and many times excess of fluid egresses from the pars plana cannula. So it's pretty useful technique if you are doing subluxated lens with vitreous prolapse in the AC. So that is one thing I wanted to add. Second thing is ki glued IOL procedures should also be taken into consideration if you are doing these kind of uh, cases, because many a times you can lose the rhexis or there can be a cut in rhexis, then you have to switch on to an secondary IOL, that is iris claw or SF IOL.
Yeah. Very valid points, definitely. I think many of these situations you need your vitreoretina consultant's support once it goes to a point of gross subluxation.
But these are your videos were excellent when these were very, very difficult cases. And thank you, ma'am.
Yeah, I hope it was useful.
Ma'am, you're a magician at work. We have a question for you, ma'am. In case of progressive zonulopathy like pseudoexfoliation with significant cataract and subluxation, should CTR implantation with scleral anchoring be the standard of treatment?
Yes, pseudo exfoliation um, based on the, of course, the age of the patient. The patient is quite old and the area of zonular weakness is less. Just a CTR would suffice, although you know that pseudo exfoliation is a progressive donopathy. But if the area of zonular weakness is more than 4 to 5 clock hours, then you would definitely look at attaching it to the scleral wall with a CTS. But it makes sense with pseudo exfoliation because it falls into that area of progressive zonulopathy. So if you have, it's not that you have overdone it if you attach these capsular bags to the scleral wall, because these are those cases which come back to you with late capsular bag dislocations. I don't know whether I've answered it. But if it's a mild pseudo exfoliation and zonular weakness, actually, I would be lazy. I would just place a CTR and get done. The patient is old.
Ma'am, I would like to ask one question. Since the iFocus platform is mainly for the students under training right now, and I'm sure they're not as skilled and experienced as you are, what would you suggest to them if they encounter a subluxation on table due to their inadvertent pulling on the bag or anything? What is a better option according to you, or a course of action instead of just losing their nerve and abandoning the case or leaving the patient with a lot of cortex in situ? What would be the next chain of actions that a young surgeon should take up
Yeah,
instead of trying to be
yeah,
very
yeah. First and
eager?
foremost, as soon as you see an area of zonular weakness, go in and inject viscoelastic. So that would actually open up the capsular bag. And then you're able to view it calmly. Actually, it's just being calm. Of course, very early zonular weakness, that you have a lot of cataract, nuclear material there, is not a very good sign. But then you do that. And then actually, before you place the CTR, you do a good hydro to see whether the nuclear matter becomes mobile. Because if the nucleus is non-rotating, then again you're stretching on the zonules and then the area of zonular dialysis will increase. And then the first thing, in the early stages, don't keep placing a CTR as a last option. Go in and put your CTR right away, right in the beginning. And once the CTR is placed, and ensuring that the eyelets, open end of the eyelets are not in the area of CTR, away from it, you position it and do place the CTR through the side port, because when you push it to the main port, you're shallowing the anterior chamber. And then there could even be a vitreous herniating at that time. So keep injecting viscoelastic, stretch the capsular bag, place the CTR. And after you have placed the CTR, why should this bag be more dialyzed than that? If it's really dialyzed, then you're still okay, place the CTR and call the surgeon if there's someone else in the place to operate, or at least um, nothing is lost. You can even suture it up and send it to the person to deal with it right away. But placing a CTR would be something very critical which you do. And then you can visualize if you can do a stop and chop or what can you do. And it has to be all very slow motion process of phacoemulsification. And once the capsular bag is, nucleus is out, then there's greater visibility. And then, nothing will happen. You can just tangentially go and strip the cortex, remove most of the cortex, remove all of it. And then you feel so good if you have completed and done the case. Only if that CTR is not enough and you need a CTS and all those things, then of course goes without saying that you take the help of a senior surgeon. But a CTR you can place, and I'm sure there are any number of videos they can learn from to place a CTR.
One thing is the flow rate should be low in these kind of cases. Bottle height should be low. um, you should prevent them, go in with minimum turbulence of the fluid.
Yes. Yes.
Dr. Piyush, you had one question, your hand is raised.
No, sir, a very nice presentation by ma'am. Almost she has covered most of the things, and the videos are very magical and very fantastic. No more questions from my side.
So,
Uh, I
yeah.
would also like to ask one more question.
Yes.
So, grossly, if a person is missing phacodonosis on table, that is a big error. But let us say what are the more commoner causes of causing an iatrogenic subluxation of the bag? What do you think in your practice, in your students, have you seen what are the most common mistakes they do that lead up to subluxation of the lens, and how the students should be very careful to avoid those particular mistakes?
If the hydro is not done adequately, you should not now go and do too much of hydro. You have to just go and tent up the anterior lens capsule, and you can just even sometimes I invariably just give one wave of fluid wave going across. But otherwise, if you then you go back and decompress and again inject another fluid wave. If you have not done a good hydro dissection and you forcefully try to rotate the nucleus, you could there in itself create a zonular weakness could get created. And then you could be, when you're going to the, if you take a phaco probe dupe into the capsular fornices, and therein you could pull on the capsular bag at that point of time. So during phacoemulsification, it's always important to chop or do a stop and chop or whichever thing you do, a divide and conquer. Divide and conquer is also a nice procedure, but get the fragments towards the phaco probe instead of taking a phaco probe to the capsular fornis. So that is one way. The other thing is the commonest time when you can have a bag dialysis when you're stripping the cortex. So, and that too, right at the end of it, when you know your mind gets switched off, you go on mentally into the other case, and the bag is not adequately distended, then you might pull on the cortex as I had shown you in that particular case. But again, if you remember, if you immediately let go on the foot pedal and inject viscoelastic and you open up the capsular bag and place a CTR, that's all that is needed in those cases. So these are those different times when you can have a dialysis of the bag.
In cases of Marfan syndrome and Weil-Marchesani syndrome, what's your preferred line of management? Do you prefer a lensectomy or you will go for a phacoemulsification?
Now, those cases are actually largely they're young, they are dealt by a pediatric surgeon. So, if it's done under general anesthesia and you can you do place a CTR and a CTS and attach it to the scleral wall, you can go ahead and do a phaco emulsification rather than. Whereas if it's an adult patient, then I would even think of doing the entire nucleus and then do an iris clip lens or a glued IOL. But in a younger patient, I would want the surgery to be confined to the anterior segment and not invade the posterior segment. I don't know. You should be the right person to tell me at this point of time.
What we do here, what we practice here is it usually comes to us and we do a lensectomy plus a glued IOL
Oh, yeah.
because subluxations in these kind of cases are almost 270 degrees and placing an IOL. Another thing, it's a progressive
Mostly
zonulopathy.
subluxated, as I showed one last
Uh,
case, those are best done as a lensectomy and then you do a glued IOL. Yeah.
and most of these cases are progressive zonulopathy, what you have mentioned in your topic.
Yeah. Yeah.
And if you have a progressive 5 years, 6 years down the line, we see all of the bag dislocating into the vitreous cavity.
Yeah.
And in these kind of situations, we then need to do a vitreous surgery, remove this lens, and do a sterile fixated IOL. So nowadays, all our this wheel Marchesani and Marfan syndrome comes to our retina clinic, and we do a lensectomy with
Supposing
glued.
it's not a very advanced uh, dialysis, you are talking of very grossly subluxated. If it is, if it is the dialysis is not very advanced, would would you still do a lensectomy? I really would like to know. I think that's the easiest way of dealing with it. But I
Yeah,
want to know whether in how young in eye would you do this?
I have done in the age of group of 4 to 6 years, and I have a follow-up of somewhere around 14 to 15 years of these patients. Over a period of time, these patients are doing good. I have done as young as 3 years, a patient in 3 years. And last I followed up maybe 5, 6 months back. The child is grown up and she is maintaining very good vision. So actually, over a period of time, if you follow this patient, the surgery looks amazing. But if you see the long-term follow-ups of these patients, because of the progressive zonulopathy, will have some kind of decentrations of IOL. And other thing is phimosis of the anterior capsule is pretty, uh, uh, we find it's pretty common in these kind of patients. And because of this, there is decentration of the lenses and there is a subluxation of these lenses. So nowadays, at our center, we manage it by lensectomy with glued scleral. We don't do much of iris claw lenses, but we do, most of our cases are glued scleral fixated.
Good.
We have one more question for you, ma'am.
Yeah.
Sorry,
No,
ma'am, you're saying something.
no. I said, is it something specific, or is this is how it is generally being done all over?
Um, and the reasons what I have mentioned,
And it will make sense.
yeah. So we have shifted and we have seen long-term follow-ups. These patients are doing good. I started with the subluxation of the lenses, Marfan syndrome, and I have follow-up. I have been doing from 2007. It's almost 16, 17 years of follow-up and we have a series of some over 2,000 patients of SFIOL at our centers. So experience is huge, and we have published this data also with good results. And actually, patients are maintaining good vision also, and we don't have much of complications. Um, the idea is also to remove the vitreous, and we do almost remove the anterior vitreous and the posterior vitreous. So the scaffold for inflammation, which is mainly there in these kind of periodic eyes, is not there. Giving that is maybe one of the reasons why we are getting more of success uh, in these kind of cases. A good vitrectomy is a must in these kind of.
Yes, nice to know.
Ma'am, another question directed to you. If we have to choose, which is safer, pars plana lensectomy or vectis removal of the subluxated lens if you're planning an SFIOL?
I think pars plana lensectomy would be the way to go, but in very young children, I would want to ask Dr. Amindra, the pars plana location itself may not be very clear, no?
No, after the age of 1 year, then the plasma. See, it's in ROP babies have a different pars plana that is 2 millimeters. But after 6 months, you can go. It's 2 to 4 millimeters. So you can proceed in with the pars plana lenses. Actually, we don't also make a pars plana. We just go 1.5 to 2 millimeters behind the limbus,
Yes.
create a sclerotomy, and we use the sclerotomy to do a lensectomy.
Yeah, true.
And we don't need to make any other extra port. And these port, we can do a lensectomy and we can externalize the lens haptic through this port and stabilize the lens with the gabor barrier.
Sir, I would like to ask one question from you, Dr. AG, sir. Considering now we have moved on to the glued SFILs, previously sutured SFILs were also being done, and the CTS also is sutured beneath the Hoffman pocket. Do you think that could be a predisposing factor for end-off cases in such patients who have undergone this extensive surgery?
I don't think so. We don't have the amount of data, but sutured SFIUL versus glued IUL. Sutured, we have shown over a period of time with UVM studies also that there is a lot of pseudo-phacodonosis. And because of this pseudo-phacodonosis, what happens that incidence of CME is as high as 15 to 20%. And because it generally, if you see, if ask the patient to move the eye, there is huge amount of pseudo-phacodonosis. So pseudo-phacodonosis in SFIUL is not there, and we have proven with UVM study while moving the eye, not much of pseudo-phacodonosis is there. So once you don't have pseudo-phacodonosis, pigment dispersion, touching of the iris to the lens, and cystoid macular edema, everything is reduced. And we do a good anterior vitrectomy with a posterior vitrectomy. Thus, the inflammation is pretty less, and the results are gratifying.
Thank you, sir. Thank you, ma'am. I think we don't have any more questions. This was an academic feast today, having two such great authorities in anterior and posterior segment guiding us through. And Dr. Piyush, sir, any closing comments from you, sir?
Uh, uh, Thank you, Dr. Chitra ma'am. Very nice presentation from your side. Uh, I just had one doubt I wanted to ask at the end, like regarding the iris claw lenses. Like we are using very less of iris claw lenses. Uh, Making a PI in all iris claw lenses, is it a must or we can avoid that?
I have done a number of iris claw lenses without doing a PI, but I think taking a PI is not very difficult. And if you can avoid any few problem for the patient in the postoperative course by doing a PI, I think it is justified too. So I think the common consensus is to do a PI now.
Yeah, it will cause, because you don't have a posterior capsule, so it can cause a pupillary block glaucoma. And then you will land up into a problem. So it's, and you, in iris claw, you don't do a total vitrectomy.
Yeah,
Yes.
you just
So,
do anterior vitrectomy.
yeah, you just do an anterior vitrectomy. Anytime the vitreous prolapses, you can land up with a pupillary block glaucoma, which can be prevented by a simple PI.
I've seen a lot of like other surgeons like not performing a PI, and I've seen post-op cases, so that's why I thought of asking.
Yeah.
So what was your experience in these kind
So
of
a lot of patients had glaucoma, like they were landing up with glaucoma, and at the end, like where YAG PI were performed, multiple YAG PIs attempt were done in those cases.
See, if you, one thing principally you should agree that if you don't have a posterior capsule, then either do a total vitrectomy, remove the vitreous, then only you won't have an pupillary block glaucoma. If you are removing a partial vitreous, always do a PI.
So it was nice for me to be on this platform. We got a lot of good information from Dr. Gupta, Arvind Gupta.
Yes.
So
Information from yours.
three cheers to you.
Thank you, sir. Thank you.
Thank you, ma'am. Thank you, sir.
Thank you. Good night. Thank you.
Good night.
Thank you.